Hi, this is Dr. Bhargava, and in this short video, I have several interesting cases to share with you all. This is our first patient, and this MRI of the abdomen shows classic features of a common hepatic solid tumor called focal nodular hyperplasia. These are more common in young females, and on T2 weighted image we see that it's almost iso-intense with the surrounding liver, and it has a central scar that shows T2 hyperintensity. On contrast enhanced images, this is its appearance. The central scar is more hypointense compared to the surrounding solid tumor. It shows uniform arterial phase contrast enhancement and some persistent enhancement, although this could be just iso-intense with the rest of the liver. But notice how over a period of time the central scar has enhanced. So this is one of the tumors that shows uniform arterial enhancement on arterial phase images, and on the other phases it can be iso-intense. It can look same or similar to a hepatic adenoma, and we want to do a follow-up MRI using EOVIS contrast if there is any doubt that a tumor is an FNH. The other classic features are that it has a central scar that is T2 bright, and the central scar also shows delayed phase contrast enhancement. This is our next patient, and they have a complex cystic lesion in the head of the pancreas. This looks like a cluster of grapes appearance. The lesion is right there. It's communicating with the pancreatic duct, and we see it here on the axial image and on the post-contrast image. It may have some septa, and the septa may show some enhancement. It's still a side branch IPMN because of its appearance of multicystic and communication with the pancreatic duct. These are benign tumors, but they're followed for a period of 2 years to make sure that there are no new changes in form of suspicious features. The ones that we look for on MR include nodular contrast enhancement and restricted diffusion. Some more images of the same pathology, a side branch IPMN in the head of the pancreas. Here is an interesting patient. They presented with rising PSA after their treatment for prostate cancer using radiation therapy, and we performed a PSMA PET-CT. Looking at the rotating image, we see physiologic distribution of the tracer in the lacrimal glands, the salivary glands, liver, faint uptake in the spleen, excretion from the kidneys into the urinary bladder. There is no recurrence in the prostate like I showed you before, and there is extensive retroperitoneal lymphadenopathy in the abdomen and pelvis consistent with PSMA avid metastatic disease. The interesting finding is this focus here in the left supraclavicular region. This is the Virchow's node, and with PSMA PET-CTs we are seeing this finding more often in metastatic prostate cancer patients. Here's our next patient, and this patient's MR of the abdomen on this coronal T2 weighted image shows this large focus of fat attenuation or fat signal seen in the head of the pancreas. When we look at the axial T2 weighted image, this is where it is, and on the fat suppressed image there is signal drop. So this is a fatty tumor that has arisen in the head of the pancreas, and on the contrast enhanced images there is no enhancement. So benign lipomas can be seen in the pancreas, but they're very rare, but they can happen, like in this patient. This is our next patient, and on this coronal non-contrast enhanced image from the CT of the abdomen and pelvis, we see a distended gallbladder with 2 large stones inside, and that the gallbladder wall shows calcifications. And so this finding is called porcelain gallbladder. This suggests that a state of chronic inflammation that can progress to gallbladder carcinoma, and the treatment here is cholecystectomy. This is more often seen in older women. All right, so moving on to an ultrasound. This is an ultrasound of the pelvis in a young female who presented with pelvic pain, and the ultrasound shows this cystic focus in the left ovary, and on the left images it has been measured, and we have 2 views, sagittal and transverse, It is a cystic focus with posterior acoustic enhancement and some low-level internal echoes. And this finding is characteristic of a hemorrhagic cyst. These happen frequently, that there is hemorrhage in a follicle inside the ovary, and it causes acute abdominal pain. Patients seek attention, and an ultrasound can show something like this. They can also get a CT where a cystic lesion with a hematocrit sign may be seen, and we recommend a follow-up in 6 to 12 weeks when these lesions usually resolve. This next patient presented with right-sided testicular pain, and we performed an ultrasound. And there are two sets of images here. The ones on the top are from the right testicle, and one at the bottom are from the left testicle. And if you look at the measurements of the left testicle, it looks normal. The right testicle measurements show that it is enlarged, and the right testicle also is hyperemic, as we see here, compared to the left testicle. Also, the entire epididymis is much larger compared to the other side and shows extensive hyperemia. So the diagnosis here is right-sided epididymo-orchitis. This is our next patient. They presented after trauma. We acquired a CT of the abdomen and pelvis, and the findings here are this subtle focus of hypoenhancement in the liver, and also a subtle focus of hypoenhancement with some surrounding fat stranding seen in the anterior aspect of the right kidney. And so these findings suggest subtle contusions involving these solid organs, and sometimes there may be overlying rib fractures in this region as well. This is a patient who presented with cognitive decline, and we performed a FDG PET-CT of the brain. Here we see the findings classic for Alzheimer's disease. On the right side, we see in a band-like fashion hypometabolism extending from the parietal to the temporal lobes. And on the left side, we see the same finding of hypometabolism extending in a band-like fashion from the parietal to the temporal lobes. And so this finding is classic for Alzheimer's disease. I'm going to play the rotating image one more time to show that the uptake in the frontal lobe is also affected, especially the frontal lobe on the right side, and there is preserved FDG activity in the subcortical nuclei, the visual cortex, and the cerebellum. This is our next patient. They came with a history of foreign body ingestion, and we performed a plain film of the abdomen. These findings are subtle when patients have ingested foreign bodies, and we start with plain films, and if the ingested foreign body is really opaque, it will be seen on the plain film. Here they swallowed several razor blades. One of them is seen right here, second one is here, third one is here, and usually we acquire serial x-rays over a period of next several days to follow them through the intestine till they are completely evacuated. All right, this is our next patient. Here we have performed a multiphasic CT of the liver, starting with a non-con. We have the arterial phase after that, portal venous, and delayed, and we see a large tumor in the right lobe of the liver. This tumor is hypodense. It is at the edge of the liver in the right lobe. There is a large central scar. When we look at the arterial phase, there is some nodular discontinuous enhancement, and this enhancement progresses from outside to inside on the more delayed phases, as we see here. And it almost seems like over a period of time the lesion gets smaller. Sometimes the larger lesions, especially the ones that are more than 5 centimeters in size, they're called giant hemangiomas. They may take up to an hour to completely fill in. We usually don't wait that long for imaging. The delayed images are generally acquired at 3 to 5 minutes, and when we see this pattern of centripetal fill in, which is characteristic of a hemangiomas, we make that diagnosis. Large hemangiomas can have a central scar. This patient should be referred to surgery because since this is at the edge of the liver, there's no normal surrounding liver tissue. This is prone to hemorrhage from a minor traumatic event, and so this should be surgically resected for that reason. This is our next patient. We have a single image from the CT of the chest showing a moderate to large sized pericardial effusion. We see this hypodensity or fluid. There is some rim enhancement of that also involving the pericardium, and it looks like there is compression of the ventricles, and there is bowing of the septum towards the left side, and so this pericardial effusion is constricting the heart, and it's not allowing it to fill in completely and empty out with each heartbeat, and that is called cardiac tamponade. Here's our next patient, and we see a complication of gastric lap band, where in these three projections we find that there is no stomach inside the gastric lap band. So the lap band has slipped out of the stomach and it's not effective anymore. So this needs to be revised. Here's our next patient, and they presented with severe abdominal pain, an older a gentleman, and we find that there is gaseous distension in this bean-like fashion in the left side of the abdomen and pelvis. And on the CT scan, the findings were characteristic of a sigmoid volvulus. We see right there the swirl in the mesentery. Here are the coronal images showing the same finding. Let me see if I can play it one more time. Going from superior to inferior, we see extensive gaseous distension, and right here is the swirl sign of the mesentery. Let's take a look at the coronal. So the diagnosis here is a sigmoid volvulus, and they need emergent surgery. All right, so a myocardial perfusion study performed with and without CT-based attenuation correction. So we have several set of images here. They're labeled stress, attenuation corrected images, stress non-corrected images. Then we have resting images, attenuation corrected and non-corrected. So we will start with looking at non-attenuation corrected images, and we find that the septum is and the infralateral wall, infraseptal wall is more active, and there is a defect here in the anterior wall. And on attenuation corrected images, that defect goes away. And when we compare the attenuation corrected stress images to the attenuation corrected resting images, we find that there are no reversible or fixed myocardial perfusion defects. So with that, we move on to looking at the function, and here we find that it's not moving well. I don't have the moving images to share with you. The ejection fraction is only 19%. So with preserved perfusion and abnormal function, we would make a diagnosis of non-ischemic cardiomyopathy. Also, I would like to point out here that the ventricle is dilated. The end diastolic volume as calculated was elevated. Also, the ventricle appears hypertrophic. There is thickened, the septum and the lateral wall appear thickened. So here is the rotating image or the source data from one of the acquisitions. And here what I want to point out is the breast attenuation. As we look at this rotating images and the heart goes around, there's a shadow, dark shadow around the heart. So I'm going to stop it and then draw it for you right there. And let me draw the breast shadow. That's the breast overlapping the myocardial uptake. And on the CT that was acquired, a low dose CT that we did for attenuation correction, we find that they have this large left breast that is overlapping the left ventricle. So attenuation correction is important, especially in heavy patients. And when we use CT for attenuation correction, it works well. And like we saw in this patient, there was an anterior wall defect that went away on attenuation correction or attenuation corrected images. All right, so this is our next patient. They presented with abdominal pain and we performed a CT of the abdomen and pelvis. We will start by looking at the sagittal image where the uterus is enlarged and the myometrium is thin, and there is hyperdensity layering in the inferior portion of the endometrial cavity. We see that here also. And so this patient was later diagnosed with a cervical cancer, and that cancer was situated right there, obstructing the outflow of menstrual blood during the cycle at the site of the cancer, with progressive distension of the endometrial cavity and thinning and stretching of the myometrium that we see here. So when there is blood inside, it will measure high attenuation on CT, and the blood products will settle down by gravity, and that is called a hematocrit sign that we see here. Here is our next patient. They presented with upper GI bleed and we performed a multiphasic CT. On the left, we have a non-contrast enhanced image. Then we have arterial phase, portal venous, and delayed. Usually when the patients are bleeding at the time of imaging, there is contrast extravasation into the lumen, and on delayed images, it becomes more intense and moves in the pattern of the bowel. And sometimes these findings are very subtle, like here. We look at the second portion of the duodenum on the non-con and then compare it to the post-con. There is slight contrast extravasation there that becomes larger over time, and then it fills up the entire duodenal cavity there. So a good example of duodenal bleed. Here's our next patient. They presented with swelling of the labia, and we performed a CT to rule out any drainable collection or abscess formation. There is soft tissue swelling, and there is some surrounding fat stranding from labial cellulitis. This is our next patient. They had a history of lymphoma, and this was a follow-up to see if there is any hypermetabolic lymphadenopathy that has recurred in this patient. And we did not see any such finding, but what we noted was that on one of their prior studies, they had a hernia. And so let me show that to you. On the CT scan right there, we see a large size right-sided inguinal hernia, and a part of the urinary bladder is herniated into the scrotum. And this was surgically corrected, and a PET CT was performed a few weeks after their surgery, and we see some post-surgical changes in the inguinal region. And then we see this focus here on the right side of the pelvis that corresponds to this heterogeneous soft tissue density, which shows some FDG uptake. So looking at the CT part of the PET CT, the density is heterogeneous. There is some low attenuation, there is some high attenuation, and that's classic of a Prolene plug that is used for hernia surgery. And after the surgery, there can be inflammation there that can lead to FDG uptake there, and that's exactly what we see here. So this is an FDG avid plugoma. This is our next patient. We performed an MRI of the pelvis in a young female. So we have small field of view, sagittal, coronal, and axial images. Here we have distended the vagina with ultrasound gel. So this is the vagina, and we see a vaginal septum right there on the coronal and here on the axial. So vaginal septums are not very common. They are usually congenital. They can be transverse or longitudinal, and they can cause problems such as dyspareunia or amenorrhea or infertility, and they may be associated with Mullerian duct anomalies and kidney abnormalities. All right, so those were the 20 cases. I hope you liked them. These are 2 books that I've written on nuclear medicine, a handbook which has videos describing all the different cases that are possible on a kind of scan, and the next one is nuclear medicine cases with multiple choice questions. There are 100 cases, each with 4 questions. These are available on Apple Bookstore. Please check them out, and thanks again for watching.